Be alright.
Ta-da.
In the UK, some 5 million major operations are carried out every year.
It'll be absolutely fine. We'll take really good care of them.
But some patients' procedures are so complex, only the most skilled surgeons can perform them.
Right, can I start?
Table is locked, we're good.
Nice, please.
Millimetres count. Your focus has to be perfect.
University Hospital Southampton pioneers techniques to treat conditions that few others dare to take on.
This is the sort of operation that you lose sleep over.
So that's the squeaky bum time.
You're always trying to push the boundaries of what's possible.
Every step needs to be done meticulously.
But being at the cutting edge of modern medicine comes with great risk.
This is the tricky bit. Right, let's just get this right.
Sometimes we're a whisker away from failure.
The surgeons bear the ultimate responsibility.
Just worried it's going to crack the bone.
Sometimes it's surgery and things can change just like that.
You are very close to the things you don't want to cut.
If it were to bleed, its entire blood volume within a matter of minutes would bleed out.
Okay, everyone away. Shocking.
I have quite a number of cases that I have never, ever forgotten when something doesn't go well. And that stays with you forever.
It's just not right.
This is what really happens behind the closed doors of their operating theatres.
We've got the lump out.
Excellent work.
You can't really ever let your guard down.
Operation's all done.
It really is the difference between the patient making it through or not.
Southampton, on the UK's south coast, and a few miles inland.
Good afternoon, University Hospital Southampton.
Is one of the country's largest medical centres.
Ready, steady, slide.
Its 13,000 staff are responsible for groundbreaking surgery and innovative research.
Sanjay, all okay from your side?
Yeah.
Providing life-saving expertise to a population of just under 4 million.
So let's stitch that to there, to hold that like that there. That is how it should be.
The hospital's specialist teams are world-renowned for their work in neuro, cardiac and cancer care.
Should we start marking?
Yeah. Performing more than 32,000 operations in its 41 theatres every year. One of its leading consultants is spinal surgeon Michael Quay.
Spinal surgery pushes you in a way that I don't know if any other aspect of orthopedics does. And I'm one of those people who needs stress to work.
For his next case, his specialist skills are being paired with those of consultant urologist James Douglas.
I think a surgeon needs to be confident. They're going to have to be resilient personalities. There's obviously a lot of pressures with the job that we do, but I couldn't imagine doing anything else. It's highly rewarding. From a tumour perspective, we want it out, but we don't want to maim him.
They're facing an operation they've never attempted together.
I'm nervous about this. I think there's a huge amount that could go wrong just from my side.
Their patient has been treated for testicular cancer, but it's spread, and he now has a tumour deep in his abdomen.
The tumour, which is, as you can see, adhered to the aorta.
It's invaded the spine and is attached to the body's most important blood vessels. While chemotherapy shrunk the tumour, it started to grow again.
He's still left with this residual mass. The difficulty we've got is with these tumours, they do have a chance of dedifferentiating, so becoming cancer again.
The tumour could be benign, but there's a chance it may become cancerous.
Is it fair to say that if we don't take this tumour out, there's a very good chance that his life will be a lot shorter?
For a man of his age, the chances of that not turning into something nasty is very, very small. It's certainly a life-shortening tumour he's got there, and removing it is therefore very important for him.
Hello, Fred.
Their patient is 27-year-old George, who received his initial testicular cancer diagnosis a year ago, just as he was starting the next phase of his life.
I studied animation, and I landed my first job in the industry. It was very exciting, and I was looking at moving out to Manchester to kind of start my life.
He was planning to move north with his friend Lisa.
It felt like a different time back then.
Definitely. Like, it's only a couple of years ago, but we look a lot younger.
George went from being really excited, looking for a new place to live, looking to start something new, and then when they said it was cancer, that was devastating.
We'd never be as carefree as we are there.
Yeah, and we've been through so much. It's changed us so much.
Yeah.
It just felt like it has stopped to everything that was normal, and nothing was normal anymore.
The cancer means George has already had chemotherapy and 3 surgeries, 1 to remove a testicle and 2 other emergency procedures to stabilize his spine and relieve the pressure the tumor was placing on his vertebra.
All right. Delivering tea.
Now George faces another operation to completely remove the life-threatening tumor. But this time the procedure carries the risk of leaving him permanently disabled.
The surgery for me coming up is scary. I've had sort of fears of the worst case scenario, but it's not really a choice. I'm told that my cancer could come back potentially more aggressively and it may not be treatable. I'd rather learn to live with the potential side effects than to live not knowing whether or not my cancer may come back. It's cold, but it's not bothersome cold.
Someone in their 20s should never have to make a life or death decision in this kind of way. It's horrible. But I think for me right now, for as long as he wakes up, that's all I care about.
The tumour is growing into the bone here.
The operation is such a massive undertaking. It will take 2 days of surgery. Michael will operate first on the spine and take out stabilizing rods inserted during George's last operation. Then he must carefully remove the vertebra where the tumor has invaded, but without damaging nearby spinal nerves, which could cause paralysis. After replacing the rods and adding 2 more for extra support, George must then be repositioned on his side so Michael can access more of the diseased vertebra, operating near the aorta, where any damage could lead to a life-threatening bleed. Finally, to fill the gap, Michael will insert a metal cage. On the 2nd day of surgery, James will need to go deep into George's abdomen and first detach the tumor from the ureter, the tube that carries urine from the kidney, without damaging it. Then James must separate the tumor from the aorta, where again any injury could cause a fatal bleed.
I've never done a tumour like this. If I damage a nerve, which is very possible, this could stop him walking. This could affect his bowel and bladder if the nerves are very badly damaged. This sort of surgery really is as bad as high risk as it gets, to be honest. Morning.
It's 8 a.m. on the first day of surgery. Today, Michael will operate on George's spine.
Happy?
A bit nervous.
Okay, understandable. You wouldn't take a young man like you and do this without a really good reason.
Yeah, and I think if it was still there, it'd just be a constant worry of whether or not there'd be more cancer.
Right, I'll see you soon.
Yeah.
I'll look after him.
All 41 of Southampton's operating theatres are preparing for today's surgeries, including Theatre E.
Guys, can we do a brief? This is a very big case.
Where a team of 16 is assembling for George's 12-hour operation.
The plan today and Friday is to get rid of what's left with a view to trying to prevent something bad happening further down the line. So today is the spinal bit. Any particular questions? No? Good.
Thank you.
It's going on a small trip. Okay. Be all right.
Right, George, we'll take it from here.
Okay, so we're going to go and roll. Ready, steady, roll.
Go, 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 go. More.
Right, everyone happy?
Yep.
Yeah, good to go.
Michael makes a 30-centimetre incision down George's back.
Go through that old scar.
Cutting through skin, muscle, and scar tissue from George's previous operations.
This is probably one of the hardest operations I've ever done. It makes you feel nervous. It makes me feel terribly nervous for George because I want to do the best for him. This is the sort of operation that you lose sleep over. Revision cases like this are always just horrible.
Many of the high-risk, complex operations at Southampton are to remove life-threatening tumours. One of its leading lung cancer specialists is consultant Alessandro Tamburini. He was inspired to become a surgeon at a very young age.
It was a very easy decision for me to become a surgeon. I had very significant health issues as a kid. I had cancer at 3 years old. I was treated with several surgeries until I was 18. Most surgeons couldn't deal with my case. There was just one person that did. I thought I could also make a difference for someone else. Because of what I had, I think probably a bit more than others, I tend to push the boundaries and push the limits in treating surgical conditions. This is a 49-year-old gentleman.
Alessandro will need those skills in his next procedure, where he'll operate with registrar Mustafa Mohammed.
He was found to have a large cancer of the right lung, which has grown very fast. It has doubled the size in a time span of 4 or 5 weeks.
Given the extension of the tumor, do you think it will be easy to achieve complete clearance of the mass?
It's not going to be easy.
Alessandro plans to remove the tumor, and with it, the lung's upper lobe, which the patient can live without.
Considering such a stunning growth, I think if we don't do this quickly, in the next few weeks, this may become inoperable. This is absolutely to prolong his life. In absence of a radical treatment, the survival of a locally advanced lung cancer at this stage is probably not more than a year.
It's nice when the sun's out.
That is nice.
Their patient is 49-year-old factory worker Nigel, who lives in Dorset with his wife Cindy.
Good boy.
Just 10 weeks ago, Nigel was told he had cancer.
When I got diagnosed, it was like my world ended that day. The feeling of cancer inside of me is very scary. It's affected me a lot. Like I said, I wouldn't wish this on my worst enemy. And for kids today and people, don't smoke. It don't help you. You know, it doesn't help you at all.
Go on, boy. Come on.
Nigel's family history has made the diagnosis even harder to bear.
Nigel was very scared at the hospital because of what happened to his mum. He was only 13 and his mum had a similar thing. And he will be praying that everything will go right for him, because when they actually had surgery on his mum, it went wrong and she never came back. And I think that's what's in his head at the moment, his mum.
I lost my mum with cancer. I've seen her deteriorate with her. It really frightened me. It frightens me now.
This has shown practically double in size of the mass, with extensive now chest wall invasion, and he has started to complain of anterior chest wall pain, which is a clear sign that this is invading through the rib cage. It's quite a large mass.
Alessandro needs to remove the right upper lobe of Nigel's lung, containing the tumour. Nigel will be positioned on his side, where Alessandro can first access and detach 2 ribs and the corresponding muscle where the cancer has invaded. Then he must carefully free the upper lobe from the pulmonary veins and arteries, where any damage could cause a fatal bleed. Finally, Alessandro will detach the lobe from the airway, or bronchus. Only then can he remove the right upper lobe with the tumour, ribs and muscle as one specimen.
The surgery is with a therapeutic intent.
The surgery could extend Nigel's life expectancy from just 1 year to 5, but it's not without risk.
You can see here the proximity of the pulmonary veins to the heart is going to be quite challenging because these are just very few millimeters away from the heart. We will really have to be extra careful in order to avoid a vascular injury that may really be a nightmare to control.
I cry on my own. He doesn't know, because I don't want him to see me break down. I just don't want to be without him. I really don't.
Hello there.
Hi.
Good morning.
I'm nervous.
It's normal. You're well aware, nothing that we do comes risk-free. Major cardiovascular event, kidney dysfunction, pulmonary edema, there's always a risk of death. I put it somewhere around 2 to 3 in 100, but the point is it can never be 0. I'll see you soon.
And you, take care.
Okay.
Thank you very much for your guidance.
All the best.
Thank you.
Thank you.
In Southampton's Theatre F, a team of 11 are preparing for Nigel's procedure.
He has a rapidly growing squamous cell carcinoma of the right upper lobe invading the chest wall.
I got told this is a 5.5-hour operation, which is a long old time. Anything could go wrong in that time. It's the loneliest feeling. Hello there. Hello.
This procedure is very rare. You can have all the training you want in your life.
Sorry, I'm a bit nervous.
No, that's very normal.
But no one will train you to do certain operations.
So Alessandro can access the ribs and lung. Nigel is placed on his side.
And roll. Yeah, lovely.
First, Alessandro makes a small incision in Nigel's right upper chest and inserts a camera to check the tumour's exact position.
This is mostly an assessment of which ribs are involved. Lungs of patients who smoke tend to be much more discolored. This is the tumor, I can feel it. And this is the area of chest wall where it's not coming off from. It seems to be clear invasion of the chest wall.
From this angle, it appears the tumour has invaded more than the upper lobe.
I think this has grown into middle lobe here. Blade, please.
To access the lung and check if the tumour has also grown into the middle lobe, Alessandro makes a 20-centimetre incision in the side of Nigel's chest.
It's definitely invasion of the middle lobe.
Sorry, Alex, is that it does involve the middle lobe?
It does involve the middle lobe.
So he's going to have a middle lobe out as well.
Alessandro believes the tumour has grown into the lung's middle lobe. While Nigel can survive without the upper and middle lobes, removing both is not ideal.
For Nigel, who is a smoker, it is important to preserve as much lung as possible because lung doesn't grow back. So his breathing function and breathing reserve after surgery will be even less. We can prepare a costotome. So I feel worried about having to remove even more lung.
In Theatre E,
Rare disease, isn't it? It's completely expanded.
spinal surgeon Michael Quay has started 27-year-old George's marathon operation.
All over the place.
to remove tumour and diseased bone where George's testicular cancer has spread and invaded his spine.
One of the major challenges of this operation is that there's no easy parts. Every single part is very hard and very risky. Right, so somewhere up here, there's bad stuff.
12 months ago, George had surgery to relieve pressure the tumour was placing on his spine. Bone was removed and 2 metal rods inserted to stabilise his vertebra. But the previous operation has created a challenge for Michael.
This is now we're getting to the tricky bit, trying to figure out how to find a way in. There's all this scar tissue around it, so this is the bit that's been giving me a bit of heartburn thinking about it. Because George has previously had surgery, there'll be very odd anatomy. It's just going to be a massive scar tissue, so the biggest stumbling block right from the very beginning is figuring out what is where.
Calculated risk, isn't it?
Yeah, don't pull. We'll,
As they start to remove bone from the diseased vertebra,
just trying to figure out where's safe to go into.
the scar tissue is making it difficult to see important spinal nerves.
That's where the nerve's going to be.
One wrong move could impact George's ability to control his legs.
And here, so where's that? That is coming straight across. At some point, the bone stops and the nerve's exposed, but it's all covered in scar tissue. So what we need to do is carefully pick away and find that cliff edge of bone so we know we can safely get into where those nerves live. You can see what I think is scar tissue. There's a very real risk we damage that nerve, which would effectively render George disabled. So that top end, that just comes under that nubbin of bone. The bone there? Yeah. Okay. Well, shall we get 7D and see if we can see whether that is the pedicle?
To get a view of where he's operating, Michael employs a 3D colour imaging system. It uses metal probes to locate and show the spine's anatomy.
Yeah, I like that. So that looks pretty accurate there.
Michael hopes it will help him identify the bone and avoid the nerve.
The navigation system is generally used for placing screws inside the bone. I've never used it in the circumstance where I'm trying to effectively map out the shape of the bone.
That looks lovely and accurate on the spinous there.
The 3D system has guided Michael directly to the bone.
Bang in the middle of the rock, yeah. Or where the rock would be.
Now he needs to remove it, but still avoid the nearby nerve.
We just need to sort of start taking some of this out, don't we?
Yeah.
Come at it from this side.
Yep, exactly that.
Good plan, well done.
There's a real risk that even pulling on that nerve, we can damage the nerve. But as I'm nibbling away, there is a risk that I can catch the nerve with my chisels. The only thing is...
Somewhere down here, L3.
Yeah.
We work our way out medial to lateral and... It's quite a better light now, actually.
As Michael removes the bone piece by piece, it's not only the nerve that's under threat.
Yeah, it's dura there. Proper dura rather than scarred up dura. It's got a little tether on it as well.
The dura is a delicate membrane surrounding the brain and spinal cord and holds the cerebrospinal fluid in place.
Yeah, it's been worrying me this bit, because if we get a hole in the dura, there's no way of containing that fluid.
Yeah.
And it would just be an absolute nightmare. It's buried and it's covered in scar tissue. Taking that off is like taking cement off a water-filled balloon. If we were to tear a hole in the dura, it would allow the fluid to leak out, and that's a real problem. It could cause the brain to sink down towards the spine and cause life-threatening injury to the brain. Stitching or repairing it would be very difficult through scar tissue. So if we were to get a hole, the hole would be irreparable. You see the dura there? Yeah. Yeah, I think be very careful of that. And that would be a disaster.
Like many cancer surgery patients, George had chemotherapy before his procedure in an attempt to shrink and kill his tumour. The treatment is most often given intravenously.
I see. We're just going to do your chemotherapy. We're running.
Great.
But these chemo bags don't come off the shelf. Each patient requires a bespoke mixture that will be most effective against their specific cancer. Amy Hill is part of a team of pharmacists and technicians who work at Southampton creating these potentially life-saving infusions.
We make around 2,500 to 3,000 chemotherapy doses a year for patients here at Southampton. Now we have a pentamidine that we need to make today. This one's a powder that needs reconstitution.
There are over 100 different chemotherapy drugs that come in liquid or powder form. They can be used alone or in combination and act to stop cancer cells reproducing. Some of the chemicals are highly toxic and outside the controlled use of chemotherapy are very dangerous to handle. So each bag is made inside a sealed cabinet called an isolator.
The medicines we are producing not only are for patients that might be at high risk, but also the product itself can pose a risk to operators and to staff. The isolator is there to protect us from spillages and keep that risk to our operators as low as possible. Some of our agents can cause allergic reactions, other could cause cancer themselves.
And I'm checking we've got 15 mils in the syringe and we need 15 mils. And we've got paclitaxel, 6 milligram per mil.
Some of the most widely used chemotherapy drugs are alkylating agents. These act directly on DNA, preventing cancer cells from dividing.
And you're going to yell, aren't you, when you've got melphalan? I can see it coming.
You got it.
Yeah.
One agent that is particularly difficult for the technicians to work with is melphalan.
Melphalan is a challenging treatment. It's often used for bone marrow transplants.
Melphalan is a time-critical drug. Once it's reconstituted, it can start to crystallize and become unusable.
You got it?
So time is of the essence.
Once we've made melphalan, we have 90 minutes. So we need to move quickly. The clock is ticking, so we run. I just thought I'd let you know we haven't got anything else. Oh, thank you very much. From the moment that we pierce the first file, we have around about an hour and a half. And that includes the half-an-hour infusion time for the patient. Melphalan in the hatch! So all along the chain, from the timing on the day to the porter delivering this to the ward, it's really important that we all know what our role is and what time the ward are expecting this to arrive for the patient. There's an incredible amount of job satisfaction working in the unit, and the team work really hard. When you bump into someone and they said someone they knew had cancer treatment here and they had a good experience, that's an incredible feeling.
So this is where we have to start our resection.
Half an hour into Nigel's surgery to remove the tumour and upper lobe of his lung, Alessandro is facing a bigger operation than anticipated.
It's definitely invasion of the middle lobe. Yeah.
Nigel's tumour appears to have invaded the lung's middle lobe as well.
I feel worried about having to remove even more lung. It would be more detrimental to have further lung loss for him. A good margin roughly here, at least a centimeter margin somewhere here, we can disconnect the rib.
Alessandro's first job is to cut free a section of 2 ribs and muscle where the tumour has grown.
Give me a peanut, please.
The tumour has stuck the upper lobe of the lung and ribs together, so Alessandro will need to remove the tumour, lobe and ribs as one specimen at the end of the operation.
As you can see, we are dropping now this portion of rib cage inside. Okay, that's good. You have a big hole. Okay, we've done the first part of the operation. Okay, now we start with upper vein. Let's just be gentle, huh? Okay. What we're seeing here is the sac around the heart. Now we're dissecting the veins for upper lobe.
To remove the lung's upper lobe, Alessandro must cut and close the blood vessels that supply it.
Can I have a loop, please?
But when he detaches the vessels, there's a risk of major bleeding.
Gun. Okay, this is a vascular staple that we use.
First, Alessandro uses a staple device to detach a branch of the pulmonary vein.
Stapling. Okay.
Now he must deal with the artery.
Okay, we're approaching the branches of the pulmonary artery. The pulmonary artery carries around 5 liters of blood in a minute, which means if we have a large hole in the pulmonary artery, we will lose the entire amount of blood of the patient in that minute if we are not able to control it, and the patient can die from a major hemorrhage. This is pulmonary artery now. It's the white one. O'Shaughnessy, please. Pulmonary artery is not tough. It's an extremely flimsy structure. Can I have a long Roberts again? You need to be calm. Occasionally you have to be a little bit brave. At the same time, never rush. No, stop. So, with the other hand, from the other side. Yes. Just the tip.
Mustafa gently threads a tape around the artery so Alessandro can get a clean cut through the vessel to detach it from the lung.
Okay, remove the blue. Okay, stapling. Okay.
Now there's just one other branch of the artery to cut.
This is the posterior ascending artery. Okay. You're not bleeding from PA.
The artery has been damaged and is bleeding.
Can I have a very set, please? From the pulmonary artery, any injury is significant. I cannot allow myself to panic.
In Theatre E,
You got the lateral edge of the dura below.
Yeah.
Michael has been struggling to remove the vertebra where George's tumour has spread without damaging the dura, the thin membrane around the spinal cord.
It's not much more from the back, is it?
Much more. That's pretty good. So that feels like bone, but not much of it. So I just need to sort of work my way down, really. Nice.
Michael has cut away the bone infiltrated by the tumour and left the dura intact.
We've taken away a lot of bone.
Pretty good.
Ready, steady, roll.
Now George can be repositioned, so Michael can access the other side of the diseased vertebra.
You all right, Pippa?
Yeah, let's go.
To do this, he must operate close to the body's main blood vessels.
Show us another X-ray, please, same as you did before.
But as muscle will block his view, Michael can't use the 3D navigational tool to locate the bone.
Just trying to demarcate where we are, front and back, because there's no landmarks here, it's just an absolute mess.
Instead, he must rely on less detailed 2D X-rays to guide him, as he chips away more diseased vertebra.
So this is where the tumour is. The tumour's in there. So what we'll start doing is just start...
The nibble.
Start nibble. Flash there, please. And I'm scratching up that anterior wall, hoping I'm not going to go through it.
At this level, halfway down the spine, Michael is operating close to the aorta, the body's biggest artery.
There is a chance that I could damage the blood vessels that just sit a matter of millimetres in front of the vertebra. That could cause life-threatening bleeding and be catastrophic for the outcome of the operation. That's a big bit. Oh yeah. Thanks. Oh, good.
Good.
Michael has removed as much of the diseased vertebra as he can, but a small sliver of bone is still attached to the tumour. It's dangerously close to the aorta, and from this position, the access is poor.
Scratch right round to the front, but right over to the other side.
Michael will need to wait and remove it during the second day of surgery, through the abdomen, when it will be easier to reach.
Tickety-boo.
Finally, Michael can insert a metal cage to replace the vertebra he's removed.
Okay, let's try it. Flash there. Oh, just a tiny knot more.
Further forward.
And again.
Yeah. That's good.
Yeah, yeah. That looks absolutely bang on. Nerve injury, dural tear, significant bleeding, vessel injury. 12 hours down. It's been a very long day. I'm tired, I'm very dehydrated, I've got a sore back, but I'm very pleased with how it went. Oh man, what a day.
Michael's part of the surgery is over.
George, we're going to go to recovery, all right?
But George is only halfway through.
George has another very big day coming up. He's got the second part of his operation, and that is another big fight for him to take on.
I just pressed on it for a second.
In Theatre F, surgeon Alessandro is removing the tumour and right upper lobe of Nigel's lung.
Suction.
But there's a bleed from the pulmonary artery.
Anytime you have an injury on the pulmonary artery, the patient can survive if you are quick.
Full step. Thank you.
As compression often can be sufficient to stop the bleeding. I prefer to have a bigger surface pressing on it, so I use the actual lung.
So keep the suction, gently remove this lobe.
I press on it for 5 minutes, and it's sufficient to stop the bleeding.
Okay. I think we're in a better position now.
Now the upper lobe has been detached from the blood vessels. It can be moved, giving Alessandro and Mustafa a better view of the entire lung.
What's that? Oh, I think it's the middle lobe.
It's allowed them to see that the tumour has not invaded the middle lobe, as they previously thought, so the middle lobe won't need to be removed.
Oh, actually, that means we're doing better. Yeah, we're leaving too. Yeah. Okay. Anatomy was tricking me. Well, luckily I have a good assistant.
The tumor was bigger than expected. The anatomy was not distorted.
I thought this was growing inside the middle lobe, which it isn't. The size of the tumor also is a big confusing factor in this case.
So it's good news for us and for the patient. The because the patient will not lose an additional amount of lung compared to what we had planned.
Whew. Okay, we're gonna work on the bronchus now and stuff.
Okay.
Now Alessandro can turn his attention to detaching the airway, or bronchi. But he must only cut the one that feeds the upper lobe.
Okay, so I'm gonna clamp the bronchus. We want to make sure we are not causing any airway narrowing, preventing the ventilation to the other two lobes. Okay, specimen should be out in a few seconds, I hope.
With the airway detached and the blood vessels cut and closed, the lobe containing the tumour can be removed.
Oof. Look at this. Okay. So this is the cancer here. In here. So the two ribs we have removed.
You happy with that, Alex?
Yes. Yeah. Yes, it was a bit of a struggle.
Yeah. Yeah, good job.
And vein anatomy also was a little bit challenging, but we've done something.
Lovely.
So no cancer is left behind. Alessandro must remove nearby lymph nodes, part of the body's immune system and a potential host to cancerous cells.
This is going to go as 4R. Right paratracheal.
It is important that these lymph nodes are removed intact because they have to be tested for cancer cells as well.
There's not much in here.
If there are cancer cells in the lymph nodes, that translates into the fact that the disease is more advanced.
Can we have a ruler?
Finally, Alessandro must reconstruct Nigel's chest, where the ribs were removed.
Okay. So say something like 10 by 11. This will be inside.
He uses a square of Gore-Tex fabric and stitches it into place.
Okay, we started the reconstruction.
The Gore-Tex mesh is an artificial material, but just like for clothes, it has a number of qualities which is very resistant, despite being quite flimsy.
This is rib 2.
It's easier to suture, and it provides coverage, it provides structure.
Forceps to me.
Over time, connective tissue will grow over the Gore-Tex and strengthen the rib cage.
That area of rib cage will always be a bit weaker than a normal rib cage, but this is something we have to accept.
Well done, everybody. I think we did pretty well in the end, most of it. We had some difficulties.
It was an interesting one.
It was an interesting one, yes. We don't do these very often.
So now that the operation is over, we are pleased of having achieved, but this is only the first step, and we will need to wait to have all the final results from the specimen.
Nigel, it's all finished. It's all gone really well.
And they will see how extensive the cancer is, and that would determine what we do next.
Even if Alessandro has managed to remove all the cancer, Nigel may need chemotherapy as a precautionary measure.
Well done, Nigel. We're just going to go to recovery now, all right?
For 27-year-old George, it's the second day of surgery to remove the remainder of his life-threatening tumour.
Morning, team. Morning.
Morning.
Thanks, everyone, for making this happen.
Today, the lead consultant is urology surgeon James Douglas. He will remove the tumour attached to the aorta at the back of George's abdomen.
It's very much going to be a two-person operation, so got Matthew Hayes here to come and help.
While Michael Quay will remove the final piece of diseased spine later in the procedure.
All right.
Thank you.
James will need to move aside the bowel to access George's tumour deep in the abdomen. Then, to save George's kidney, he must separate the tumour from the ureter, which takes urine to the bladder without damaging it. Then the tumour needs to be carefully cut away from the aorta, the body's biggest artery. Damaging it could result in a fatal bleed. Finally, the last section of vertebra will be freed, so the entire tumour can be removed.
I stay relatively calm in the build-up to surgery. Obviously a little bit apprehensive.
1, 2, 3. Perfect.
Certainly the stress levels rise quite considerably at that moment. You feel your heart rate pumping and you're trying to keep yourself calm.
Scalpel, please.
James makes a 40-centimetre incision from the bottom of the breastbone to just below the navel.
Okay, let's have the Omnitrack, please.
Before using a retractor to move aside the bowel and access the tumour. After cutting through connective tissue, James reaches the first structure he must free from the tumour.
So this is our aorta coming into view. Have some forceps, please.
As the aorta carries 5 litres of blood every minute, James must treat it with the utmost care.
Quite tempted to go for control of the aorta now. Vessel tape, please. Nylon tape.
As a precaution, James loops tape around the vessel. If it's injured, he can pull the tape tight to stem the flow of blood.
If we get bleeding from here, we can turn off the aorta there. We've got aortic control there, we've got aortic control here. And we identify his ureter on this side.
But before he can try and get the tumour off the aorta, he needs to separate it from the ureter, which drains urine from the kidney.
Right, so there's his left ureter.
If the ureter can't be freed or is damaged, George's left kidney won't function and will have to be removed.
And it does go quite close to this on the scan to the tumour, so we'll see. It might be a reason why we lose the kidney, but hopefully not.
Ureters are very fine tubes, very thin-walled. Particularly post-chemotherapy, they can often be like tissue paper, so they're very delicate. We have to handle them with care.
We're completely plastered into the scarring, aren't we?
Yeah.
The post-chemotherapy scarring can be very severe, which therefore makes the operation quite tricky to preserve everything without damaging it.
So this is just scar tissue, but it always feels a bit disconcerting. Good. Okay, so we can take the kidney that way nicely. So our kidney's coming off beautifully.
So I'm very pleased that we've freed the ureter now. I'm happy he can keep both kidneys, which will be much better for him long term.
With the tumour off the ureter, James can turn his attention to where it's stuck to the aorta.
Right, I think I'm going to thin that out a bit by coming down the aorta side. Go that way.
This is the trickiest part of the operation. We risk tearing a hole in the aorta, at which point catastrophic bleeding is possible. The stakes don't get any higher in these big operations. Patients can die due to major blood loss.
Going down there, huh? Yeah.
You can see completely up against the aorta, but we have a surgical plane, it's coming off.
This is the point of the operation where I really try and slow things down. If we can avoid bleeding at all costs, this will have a much better outcome for George.
After 20 minutes of painstaking work to free the aorta from the tumour,
coming off.
James's goal is in sight.
Right, well, I think we can say Aorta's off.
All right, for that.
That's really good news. Okay. Funny, isn't it? It was some sort of fleshy mass out the back of the cave that we weren't fully expecting.
But just as James thinks the hardest part of the operation is over, he's discovered enlarged lymph nodes attached to the back of the body's largest vein, the vena cava.
These are potential landing zones for the tumour.
The texture of them is a bit meatier than I would expect, which makes me concerned that there could be some cancer in there. So it's very important that we clear all of these out.
Can I have 4 sets, please?
The vena cava is very thin-walled. It's very easy to go into it, and blood tends to well up, so you get a big rising puddle of blood. You could easily fill the abdomen with blood within a minute, so it can be quite hard to see where the bleeding is coming from.
5 minute look, eh? Let you know, cancel that, I'll have a try, yeah?
The lymph nodes must be gently peeled away.
Right, so then that's all good. So all around our vena cava here nicely. All cleared out. I'm very happy with that. Aorta's preserved.
With the last lymph node out, James can now free the tumour from the back of the abdominal wall.
So in terms of getting this tumour now, where are we going to be best from this side?
I think for the apical bit, probably, yes.
We are, aren't we? Nearly there. We're just above the tumour, so we're good.
The tumour is now only stuck to the tiny piece of vertebra.
All good?
Well, Mr. Quay, yeah, I think your time has come.
Lovely.
A job for spinal surgeon Michael Quay.
So we're now starting to come down, so on the bottom half we're there.
Yeah. Go ahead, Tony, please. Oh, I like that too.
We've got the lump out.
Surgically, this is the culmination of 2 very big operations, and we're very happy that things have gone so well. We think we've given George the best chance.
It will be 2 weeks before tests reveal whether the tumour or lymph nodes contain active cancer cells.
There we go, keep you all covered up and warm. Happy to go?
Always.
Yeah, brilliant. Right, just concentrate on those nice, slow, deep breaths for us.
Hopefully we'll see what happens today.
It's been 2 months since Nigel's operation.
Good afternoon.
Can I come in?
Yeah, certainly.
Today he's returned with his wife Cindy for an appointment with surgeon Alessandro Tamburini.
Have a seat, sir. From perspective of recovery, you're getting fitter as well?
Yes, I'm walking more.
The good thing is that we have completely removed this.
Yeah, good.
There is no cancer at any margin. Also on the rib cage, everything has been completely removed. So this
Thank
is
you
a
very much.
fantastic result. I think it's extremely important to consider that you will probably need to have also chemotherapy as part of a more comprehensive treatment. With best radical treatment, the chances of being cured after 5 years, I would say, are a good 30 to 40%. Okay.
I understand, yeah. I feel 100% better. I feel more alert now. Like I said in the beginnings, when I was going through it all, I started losing energy and things like that, and my chest started hurting a lot.
You didn't want to do nothing?
I didn't want to do nothing, no. I thought it was the end, you know what I mean? But now it's the beginning to me. I can't thank you anymore, you know what I mean? I can't.
It's my job.
No, seriously, thank you. I mean, you've done your best, and you've given me another life.
Thanks.
I understand. You're angels. You all are. And I would like you to thank your team as well for me.
I will do.
Thank you very much for that. All the best, my friend, yeah?
I do feel sometimes that I'm carrying on a legacy of the surgeon who saved my life as a child. Very successful surgeon that helped thousands.
All the best, thank you. Thank you very much.
I wouldn't compare myself to him, but you know, I remain convinced that I'm doing a good job and that he would be proud of me.
Weeks ago, George underwent a 2-day surgery.
George?
To remove a life-threatening tumour. Today, he's returned with his mum and dad to see consultant James Douglas.
Pretty much 4 weeks to the day, isn't it?
4 or 5. Yeah.
How are you?
I feel okay.
Yeah, so everything we removed, that mass we were taking out, there was a tiny, tiny little bit of cancer in there as well.
So that was still live?
Yeah, still live tumour.
Even after all of that
chemotherapy.
Yeah.
So the bulk of the disease, and that's all gone.
Okay.
I think it was the right decision to do. Big as it is, like you say, it was always a risk, but I think it was the right decision.
Well, yeah, I mean, the tumour would have come back. The longer we go with no recurrences, the happier we are. But the majority of people sitting where you are, we expect to be cured.
Okay.
George is going to need some close follow-up for many years to come, but we all remain optimistic that his disease does not come back and he can have a long, productive, fruitful life ahead of him. You've done brilliantly.
Yeah. Everything seems to be going well so far. So.
Yeah, and it will continue to go well.
Okay.
The reward of seeing George looking well makes the surgery worthwhile. So I think that's what pushes us to keep doing it.
We'll probably see you around.
You will. We'll definitely see me around. You won't lose me.
Look. Good boy. The surgeon called me directly and said how it went, and it was just such a relief. It was like all of the worry was just suddenly lifted. It was amazing. Finally, everything is done and it's all over.
Come on. It definitely feels like I have this kind of opportunity to live life again, like a second beginning for me. I do owe my entire life to the surgeons. What's up, Grandma?
Grandma.
Everything that George went through and the pain and the stress and the anxiety and everything else that went with it was worth it.
Come on, Grandma.
Grandma.
We're going home now. It's nice and warm.
Importantly, that decision to do an operation that could have killed him was the right decision. It was worth the sleepless nights.
Your hair's probably thicker than mine now.
Yeah, thicker. Definitely. It's always been thicker than yours.
Yeah.
Next time, 2 life-saving operations.
Then we will slowly get you off to sleep.
The blade, please.
Complex cancer surgery.
It feels really stuck.
Where failure is not an option.
I think it's going to be hard work for every centimetre of this operation.
It's a bit oozy here, oozier than normal.